Good evening and welcome to Doctors on Call. I'm Dr. Paula Termulin, Regional Campus Dean at the University of Minnesota Medical School, Duluth campus, and I'm your host for our program tonight on women's health and female cancers. The success of this program is very dependent on you, the viewer. Please call in your questions and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Mark Widstrom, an OB-GYN specialist with Essentia Health, Dr. Sandy Stover, a family medicine physician and faculty member at the Medical School Duluth, and Dr. Verna Thornton, an OB-GYN specialist with the Community Memorial Hospital Family Clinic in Cloquet. Our medical students answering the phones tonight are Claire Donovan of Alexandria, Minnesota, Julia Laswell of Rockville, Minnesota, and Becky Winchell of Sartell, Minnesota. And now, on to tonight's program on women's health and female cancers. Dr. Widstrom, I've been hearing a lot about pap smear guidelines. There's been a lot of changes going on. Can you talk to us a little bit about what you're seeing in your practice right now and maybe some of the challenges of meeting those guidelines?
Yeah, over the years, the guidelines change constantly. About every 5 years or so, they review those guidelines. The most recent one have the guidelines set that we start pap smears at age 21 for screening, with the exception of certain conditions. If there's a significant autoimmune disease or HIV, then we would start them earlier potentially. And from age 21 to 30, the guidelines say to just do a pap smear only every 3 years. And then from 30 on to up to age 65, the guidelines are a pap smear plus screening for high-risk HPV, which is the type of virus that causes most of the cervical cancers. There are other subtleties in that of if a certain type of pap smear comes back, then it will get reflexed to an HPV if somebody is in their 20s, and you're already checking that HPV after age 30. The other option is after age 30 is just to continue on with just a pap smear every third year and not doing the HPV screening.
Okay. And so really for a lot of reasons, I can see where this could be confusing both for physicians, I think, and for patients just trying to keep that all in mind.
Yeah.
So
the one confusing thing is a lot of women equate a pap smear with their pelvic exam. And so women should continue to get pelvic exams yearly. And each year is decided between them and their provider whether they should get a pap smear that year or not.
Okay.
And it would depend on their history, whether they've had any changes in the pap smear in the past.
So, Dr. Thornton, I know you take care of a number of older patients.
Correct.
And let's say you have that healthy 65-year-old woman, and we just heard from Dr. Widstrom that maybe we're stopping those pap smears at 65. I mean, do you do any different counseling for those women?
Absolutely. As you already referred to, women who are over 65 have a different and unique set of health concerns. And we have to take into account what was the reason, that their past life may have been requiring them to have a hysterectomy, or what was their childbearing history. So those things have to be taken into consideration at, older age. A lot of women hear that once they've had a hysterectomy, they don't need to see a gynecologist anymore. And that is a really, really big misnomer. And we need to get the message out that a lot of women who've had hysterectomies still may have their cervix. They may have had a supracervical hysterectomy. They may still have their ovaries. So again, not needing a pap smear, is highly dependent upon the patient as well as their former history.
Okay. So on a related topic, since we're on sort of the theme of cervical cancer right now, Dr. Stover, HPV vaccine. Can you talk to us a little bit about that?
Well, I think the HPV vaccine has been one of the best things to come along. It's really the first vaccine that gives us an opportunity to prevent and to get in the way of cancer that's pretty aggressive. It can be, in people that for which it kind of gets loose. So the vaccine is available for men or girls and boys as young as 9. The ideal time is between 11 and 14 to get the vaccine. The earlier you get it, it's actually more effective, and so you only need 2 shots if it's between that 11 and 14 age, and over 15 it's 3 shots.
I was going to say there's a little bit of a different recommendation than there was before, right?
Right, and the other change in the recommendations has been extending that time. It used to be right up to age 26, and now they're really finding good benefit up to age 45. For people who have tested positive for HPV, there's actually good benefit for getting the vaccine as well. There's a reduction in cancer outcomes even if you've already been exposed to the virus and have that on board. So
And
wonderful vaccine.
The adding just the new vaccine covers 9 different types of the high-risk HPV, whereas the former one only covered 4 types.
Wow.
But they don't recommend, from what I've heard, that if you already have had the 4-valent, the 4-type one, you don't need to get
You don't need to be
for the
revaccinated.
next
No.
Well, have you all had any patients, or at least parents, who have concerns about the additives in these HPV vaccines and all of the hoopla about young girls having neurological deficits following those vaccines?
Really nice study that came out looking at, it was kind of looking at a whole bunch of studies and correlating the data. It came out just in this last summer, that the outcomes for people who have the HPV virus in terms of potential side effects are the same in the group that had the vaccine and the group that didn't have the vaccine. So
That's really
we are-
important information.
We are all in a situation where things happen, and there is not a proven connection between the vaccine and any significant side effects to that vaccine.
But we've all seen plenty of repercussions from untreated HPV.
Yes, for sure. Yep.
I've actually heard some people say that we may be able to cure cervical cancer with this vaccine, as in cure it as where we won't see it again if we get enough people. And I think that would be terrific. So,
Well, I don't know about a cure as far as, immediate, implications, but certainly we're well on our way to reducing the absolute
Yeah.
incidence of cervical cancer. One of the things we know is that cervical cancer usually peaks at around age 50, so it's a disease generally of younger women, and it certainly should be able to be eradicated if we start following more stringent, guidelines in terms of administrations of the vaccines.
Viruses are kind of sneaky things. I think that it's important to really be vigilant, but we have been blessed by having a strong CDC in this country that actively looks at opportunities to intervene with a variety of diseases and vaccines. And I think the technology that's went into developing the HPV is being looked at for other potential infectious sources for developing cancer. Yep.
all right. So we've got some callers, and they're participating with us tonight. And so this is great. We have a couple of questions. Becky from Duluth would like to know that in adult women, how common are irregular periods, and is there any risk associated with that?
Irregular periods?
Irregular periods.
Well, regular menstruation is usually pretty much defined as the interval of at least 21 to 35 days between the beginning of one menstrual cycle and the beginning of the next. Anything that falls outside of that is, a little bit irregular. Now, if it occurs once or twice, it's not really a major issue. If it's something that's ongoing and problematic, irregular periods can be associated with a number of other disorders: polycystic ovarian syndrome, thyroid disease, and I'll let my colleagues elaborate a little further on their experiences.
Yeah. Also, it could also be getting, as you get closer to menopause, if the periods become more irregular, associated with precancerous change of the uterine lining or uterine lining cancer.
And I think it's important that if you've had a very regular history and then it becomes irregular, that is something to talk about with your primary provider to see if, you may want to start thinking about potential menopausal changes, which could impact your fertility, which could impact whether you're on birth control or not, but also to look at things like thyroid disease it can certainly show up in women more than men.
And also for women who have gone through menopause, which again, we can get into some, school book definitions, but the absence of menstruation for at least a year, any bleeding after that is postmenopausal bleeding and requires a whole different subset of evaluation.
Well, along that spectrum, Sandy from Duluth would like to know, in the postmenopausal person, what is the brownish discharge that someone may experience? How do you treat it? Is it a problem? Is it something to be worried about?
And I would say if you're having discharge, again, that's different than your normal body discharge, that should be checked out. Brown is a little concerning color because normal body fluid tends to be a little bit lighter than brown. I do sometimes see brown if there is potential for a low-level inflammation that could cause some bleeding to be sitting.
But it could also be atrophic vaginitis.
And it could be atrophic vaginitis.
And that's probably the herald discharge color of women postmenopausal who come in. They've been treated multiple times for bacterial vaginosis, yeast, and so forth and so on. And it's really none of those things. And so, again, regardless of color, if there's a discharge that is abnormal, whether it's in color or character or amount, you do need to get it checked out.
Okay. So we have an email from Lee who has a question that I think is going to require a little bit of thought on our part. Should a young woman who's had bilateral mastectomies but gets pregnant be concerned about postpartum breast engorgement? Have you run across that?
It's actually, I have in certain kinds of situations with breast reductions or, and if there is any breast tissue present, and some, depending on how mastectomies are done, there may or may not be, you can have some engorgement of the ducts that are still in place, the milk-producing glands that are still in place. For women who've had a complete mastectomy, it's less likely to see enough tissue to be very noticeable. But if it's something where they're swelling with pregnancy in any body part, I think it's worth checking in with your gynecologist.
Well, you know, we're doing a lot more genetic testing now, and some women are finding out very early and then taking steps to reduce their risk for breast cancer by having bilateral mastectomies. And one thing we're able to offer women now are nipple-sparing mastectomies, and that will have a small amount of breast tissue. So I can imagine that could be a scenario.
It could be uncomfortable if
Yeah, it
they're
could be very
swelling in that area.
uncomfortable. And of course, there's no milk that will be produced, really, but that feeling could be very uncomfortable. So, all right. Well, here's some other things that are on people's minds. We had a question from one of our medical students, actually, thinking about the use of IUDs. If someone has one in place, how long are they good for? Are there any hormonal changes that are associated with the use of the IUD? Dr. Woodstrom, what's been your experience?
The main type of there's two different basic types of IUDs. There's hormonal releasing IUD and non-hormonal, which is a copper IUD. The copper IUD is good for up to 10 years right now, and does not release any hormones. In general, women may tend to have a little bit heavier bleeding with the copper IUD than their normal, but not necessarily.
Okay.
The hormone releasing IUD, there's three different types of that. One is meant for 3 years, and the other two are meant for 5 years. One is a little bit smaller, and the most common one is the Mirena, and they're all just brand names, which is good for 5 years, but may be used longer. Some studies are showing, up to 7 years even for the, and they may change that, how long they're able to be used. Some of the benefit of the hormone-releasing one is just progesterone, and is that it can decrease the amount of heaviness of bleeding, and we'll actually even use it for treating bleeding problems. If a woman has a heavier period and doesn't really need contraception, we might even use it for that.
So just thinking a little bit about the different types of contraception, where is the IUD fall right now in terms of popularity?
Extremely popular. I think I'm probably the queen of Carlton County when it comes to putting in progesterone-releasing IUDs. One other point I would like to bring out and caveat is they're not meant to be there forever. And every now and again, we've all encountered the rare woman who feels, okay, it's been in there, it's working for me, and they leave it in for longer than the recommended 5 years. And the risk that portends is that you may end up needing a surgical removal. So I would again want to urge my young ladies to, and my older ladies to make sure that they do get an annual checkup to make sure that the IUD, whichever one they've chosen, is in fact intact and in place. But it's a very, very common form of contraception, and in my practice, it's overtaken birth control pills.
And it really is the most effective form of contraception.
It's also very cost effective
Very
too,
cost effective.
because of the number of years that you have it in place. It's less expensive than birth control pills, and most insurances have recognized that and tend to be pretty good at covering that.
And it's more effective because it reduces user error.
Yeah.
Yeah, there you go.
Yeah.
All right, so let's step back for just a moment to the topic that we had before around pap smears and abnormalities associated with that. We had a question from an individual who'd like to know why their doctor might tell them to wait a year after they'd had an abnormal pap smear, especially someone who might be over the age of 60.
It depends when we talk about abnormal, what that means is there's different degrees of concern and different degrees of sort of changes in the cell type to the more concerning types. So if there's a change that can be consistent or is difficult sometimes to tell from what happens as a normal part of aging, and your HPV is negative, or even when it is positive, our bodies are good at kind of helping manage that. So there's a good algorithm in place to help guide, do you really need a procedure done which has its own risks associated with it, or is it something that statistically shows most people with this tend to clear it normally on their own. So abnormalities is something to talk about with your physician. Is what does that mean? And abnormality being something that's concerning for actual change in the cell type, or is it something that's just showing some beginning changes that could be consistent with the virus being present but not yet causing tissue damage, kind of thing.
So the idea that you would have that repeated then at a different time point in the future.
Depending on the finding, and one of the things I think we also need to mention is that human sexuality patterns are changing. And that while a woman may be 60 and above, women are living longer, having more partners, engaging in more, shall we say, relationships would be the nice, polite word. And certainly we have to take that into account. You know, it's not as though these women are grandmothers and grandmothers alone. They still have full lives, and we do have to take all of their lifespan into account. And that could account also for some of the abnormalities in PAPS.
All right, fair enough. So we have a couple of questions coming in now around different types of female cancers. One person would like to know how common ovarian cancer is, and someone else would like to know whether or not endometrial cancer is being seen more and what the screening might be for that. So let's talk about those sort of broad topics of endometrial cancer and ovarian cancer. And I think actually for our viewers, just even talking a little bit about the difference between the two, because female cancers can get a little bit confusing based on your understanding of anatomy. So,
with ovarian cancer, the sneaky thing about ovarian cancer is the symptoms are very broad and very general at the beginning. And so a woman might just have some bloating. They might have some bladder discomfort or bladder symptoms or change in bowel habits and not really realize there's something that's changed from their normal before the cancer's gotten more advanced. And the most common type is a serous type of cancer, which is a epithelial kind of or a skin type cell. And one thing that has been found is that it actually starts in the fallopian tube. And the last several years, the recommendation is if you're doing another type of surgery and the woman is done having childbearing and does not want to have children, to remove the fallopian tube while we're in there doing, say, a hysterectomy but leaving the ovaries. Or if we're doing a tubal ligation, we try to remove the fallopian tubes now as opposed to just separate the tube, because it decreases that specific type of cancer, which is the most common, by in the range of 65 to 70% decreased risk.
okay.
And the lifetime risk, there's a range, but about 1 in 40 chance of having ovarian cancer lifetime.
Okay. Okay.
The most common cancer, if we're talking about gynecologic cancers, is actually uterine cancer, followed by ovarian and then cervical, and then of course fallopian tube being the rarest. And the average age for uterine cancer is about in your low 60s, 62 to 64, with the vaginal and vulvar cancers being a little bit older, about 67. So again, you know, it's important for these ladies to still go and have an annual well-woman exam. Even if they've had a hysterectomy, they may still have ovaries. Whether they've had, you know, their ovaries and uterus removed, they still have vulva and vagina, which the risk does increase with age.
So endometrial cancer is and uterine cancer are the same,
That is correct.
and it arises in there. I'm sorry, Dr.
No, I was going to say the exact same thing, just
Oh,
in terms of words and terminology, because we do sometimes think of
Flip-flop.
them as different things.
Yeah.
But the endometrial lining is the active part of the uterine growth that helps in terms of being able to support a baby when that time is right. And so those more rapidly growing cells tend to be where cancers arise first, and that's the hallmark for endometrial cancer is a bleeding that's not normal for a woman. So postmenopausal bleeding is a big red flag. You know, if you've not had a period for a year and you start bleeding, you need to see your primary care physician. But there isn't really another way to kind of screen other than doing PAPs or being aware of the different kinds of symptoms and like postmenopausal bleeding can come. And I have done PAPs on women and had the endometrial cells that are present be that red flag to go looking further and find that they had a low-grade early onset of some endometrial change.
So I think you've just hit on something I also want to emphasize, I think, for our viewers, is the idea that don't be afraid to get things checked out, because
Right.
the sooner something gets recognized, particularly with these cancers, this is an opportunity for, for treatment at an earlier phase.
Yep, earlier is better.
And unfortunately, there's not a good screening test for ovarian cancer either.
Right.
And the caveat on that would be is if there's a significant family history and maybe one of the cancer genes like BRCA, or the other is Lynch syndrome, if there's a family risk or a known gene problem, then we do much more vigilant screening for ovarian, such as getting an ultrasound every year or checking hormone level for something called CA-125 every year, a cancer marker. But that's not for the routine public, the general public that doesn't have a high risk.
And the genetic counselors could come in and be partners in this as well, in helping give individuals some idea of their risks and what they may want to choose to do in terms of screening for.
But we also have to be careful about, as you just mentioned, the CA-125. In my practice, I've had, over the years, numerous women who come in requesting it. And one of the things I think the audience, listening audience and viewing audience needs to understand, it's not a screening test like a mammogram
Right.
for breast cancer or a pap smear for cervical cancer. It's wonderful as a diagnostic tool if it's very, very high. It's wonderful for tracking and following ovarian cancers, but it's not especially helpful in terms of initial screening because you can get false positives for a lot of other reasons beyond and aside from ovarian cancer.
All right, let's go a little bit of a different direction now. Lily from Duluth has a question about the ability, reproduction capability with a single ovary. So a person has a single ovary versus 2 ovaries. Does that change their ability to get pregnant?
You do the obstetrics. I'm going to let you take the lead on this one.
As long as that ovary is still producing eggs, it really shouldn't decrease their fertility. And women also have heard worry about, so there's an ovary on this side, but that tube's gone, and there's a tube on this side, but that ovary's gone. It doesn't really work like that. It doesn't matter. The ovary will ovulate, and that comes in to the abdominal cavity, and something magical happens that the egg finds that tube opening, and within the fallopian tube, sperm meets the egg and causes ovulation in the fallopian tube, and then it descends into the uterus. And so you see pictures where the ovary's here and the tube is draped over it like this. That's not how it works, really.
So there's actually 2 messages embedded in what you just said. So for the woman who has a single ovary and wants to get pregnant, then there's still a very good possibility that this can occur.
Yep.
On the other hand, if there's a tube on one side and an ovary on the other side, don't think that you don't need to worry about preventing
Control.
pregnancy, right?
And there's a third caveat. If you have one ovary and you're older, meaning you're over 35, you can have a test called an AMH, an anti-Mullerian hormone test, that can kind of give you an idea of your future fertility in terms of your fecundity. I can't even say it anymore, fecundity. The ability for you to look and see how many eggs you have available, possibly to
Be fertilized.
get pregnant, be pregnant. How about that? Simple word.
All right, so it's October, and I have to make sure we get this question in because it is Breast Cancer Awareness Month. Why is there an increase in breast cancer, young and old?
And I think that it's an interesting question as to whether there's actually a larger number of women who have breast cancer or a better way of catching cancers across the board. And I guess I haven't seen the statistics that there's actually more cases,
Right.
and particularly the cases that are more aggressive. I think, in this world, there's a lot of reasons that cancers and things form, and with breast cancer, with better technology in terms of finding at earlier ages, there's a lot of intervention that can happen to keep it from getting to the point where aggressive treatment is needed.
Well, and I'll chime in a little bit and just say that I think you've hit on an important thing. So breast cancer in North America, in Caucasian women, #1 incidence in the world. African American women, #2 in the world. So the point is, in the United States, we have the opportunity to do really, really good screening. And there's a lot of new things coming online to help us identify breast cancers early, the 3D mammography being an example of that if you have dense breast tissue. And also, as we were touching on genetic testing that we might want to do for some of the pelvic cancers, this is also something that we're doing more and more of for women who may be at risk for breast cancer. So in some respects, we're actually identifying and becoming much more thoughtful about who might be at a higher risk for breast cancer. So.
What about some of the lifestyle changes? Could we address that for our population? Weight being a big one.
Thank you for that, Dr. Thornton. You're absolutely right. We know that obesity is associated with the development of breast cancer. It has a lot to do with the hormonal influences that the fat that we develop in our bodies can sort of transform, if you will, into those hormones that can drive these cancers. So,
Well, and exercise itself is a good preventer as well.
Yep. Moderate to heavy alcohol use increases breast cancer risk as well.
So,
And what are some of the things that don't cause breast cancer? Do you hear all the time about birth control pills?
Causing breast cancer.
Yeah, that's never been proven, and you're the expert on that. Would you?
yeah, no, that's actually, in some studies, there's been a protective effect of birth control pills.
Yep. And their
So-
protective effect for ovarian cancer as well.
There you
And
go.
uterine cancer. Yeah.
Yep. Yep. So, so I think we've got a lot on people's minds. We'll finish up here with one quick question. What can cause cervical prolapse, and how can it be treated? What ages might that occur? So cervical prolapse. We've only got a minute, so we'll go ahead and finish with that question, I think.
Well, first, I think maybe a definition of what cervical prolapse itself is. And the cervix is in someone who's not yet had babies is up and is sort of the entry into the uterus, and it sits at the end of the tunnel of the vagina. But when the tissue around the vagina has been impacted in some way, particularly with childbirth, it can loosen in a way that sometimes that tissue can come forward and cause some bulging at the opening of the vagina. And so there's different kinds of tissue that will prolapse forward, and you guys are the ones that do surgery, so you can talk about it. But there are some non-surgical ways that can help reduce the chance of that tissue being able to come forward with the pressure of bearing down, to have a bowel movement or lifting heavy things. Lots of things. That
So
can be done.
something for you to talk with your doctor
Yes.
about. So with that, I really want to thank our panelists, Dr. Mark Widstrom, Dr. Sandy Stover, and Dr. Verna Thornton, and our medical student foam volunteers, Claire Donovan, Julia Laswell, and Becky Winchell. Please join Dr. Casey Capella next week for a program on aging and Medicare wellness exams, when her panelists will be Dr. James Conniff, Dr. Rachel Gordon, and Dr. Addie Vittorio. Thank you for watching. Good night.